The following podcast is part of a certified educational activity titled Immunotherapy for the Win Against Melanoma: Strategies for Integrating Innovative and Next-Generation Immunotherapy Options. Access the entire activity and complete the post-test at peerview.com/GUW860. Downloadable slides and practice aids are also available.
Tonight, we're really honored that you'd take your evening on a Saturday night to come and hang out and hear a little bit about melanoma. Hopefully we'll have a chance to educate you a little bit, or at least reinforce some things that you already know. So we're going to go through our slide deck here, and so I'd like to just quickly say thank you also to the panelists here. They're going to introduce themselves a little bit later, but obviously I'm Jason Luke. I'm going to be chairing the session here today and giving some of the talks, and Kari Kendra from Ohio State is here, as well as Meredith McKeon from Sarah Cannon. So just level set for the meeting here. I think all of you in the room probably are aware of this as you're attending ASCO, but that the therapeutics that are available for melanoma have changed dramatically over the past several years, obviously, where we have sustained overall survival improvement with immunotherapies as well as targeted therapies. And here we see an overlay of the various Kaplan-Meier survival plots from all the seminal clinical trials that really inform clinical practice right now. And you can see they're listed on the right-hand side. I won't go through all of them because I think you're probably well aware of most of them, but except to say that, just a reminder that when I started my career in 2012, the median survival of melanoma was 9 months. And now the median survival for melanoma is not reached, meaning we don't know what it is. And so that's a really amazing changeover, and I think it emphasizes the progress, but actually has some complexity about how should we best manage patients, and we're going to talk through some of those things here tonight. But so these challenges do remain. I talked about that aspirational survival. It's really predicated on long-term response to immune checkpoint blockade, and survival is poor in patients who actually progress on immune checkpoint blockade. So those patients who don't go into durable response still have those same outcomes, unfortunately, that were circa 2010. We see an advance more recently with PD-1 and LAG-3 combination, but if that doesn't work, again, choosing an effective therapy can be challenging. And treatment patterns in the National Cancer Database, noting there with more than 8,000 patients with stage 3, shows that only about a quarter of patients more recently are receiving adjuvant immunotherapy after surgery. And it's interesting to see that. There could be multiple reasons why, but we're going to talk through some of that data again, how preventing relapse also could potentially enhance long-term outcomes. And some earlier stage patients, such as those with stage 2B and 2C disease, are in fact at very high risk of disease progression to metastasis, and may or may not actually be getting the most optimal therapies. And again, we're going to go over some of that today. So our goals here today are to improve our understanding of current evidence and guidelines surrounding the use of established and emerging immunotherapies for resectable and unresectable melanoma, to equip all of you with the skills you need to develop evidence-based treatment plans that include immunotherapy for a wide variety of patient presentations, and to provide you with guidance on how to manage unique adverse events associated with immunotherapy for patients with melanoma across the spectrum of disease. So the next wave of immune options for advanced unresectable melanoma will be the first part of our talk today. And we're going to sort of hand the meeting over then to our first speaker, who's Dr. Meredith McKeon, to talk about PD-1 and LAG-3. And I'll just give her a chance to update, to introduce herself as opposed to me butchering it, from the beginning. So.
Sounds great. Thanks, Jason. So thank you all for being here this evening. And I echo, hopefully this can be interactive, and please feel free to ask us some questions. So I'm Meredith McKeon. I'm a medical oncologist. I lead the Melanoma and Skin Cancer Research Program at Sarah Cannon Research Institute in Nashville. So tonight we're going to be going over kind of new therapies available in metastatic melanoma. So PD-1 LAG-3 combinations are now part of our standard of care frontline therapy. So this is a copy of the NCCN frontline therapy recommendations, and you can see based on the data that we're going to discuss tonight that nivolumab and relatlimab is now category 1. And so this is that means the strongest evidence to be considering this for your patients in the frontline setting for patients with metastatic disease. So how did we get here? So what is LAG3? So lymphocyte activation gene 3 regulates a checkpoint pathway. So it's another checkpoint inhibitor, LAG3. So LAG3 actually promotes an immunosuppressive environment. And so LAG3 and PD-1 receptors are overexpressed and are co-expressed on tumor-infiltrating lymphocytes in melanoma. And so you can see here the rationale for inhibiting LAG3 in potentially the IO-therapy naive and IO-therapy experienced setting. So you can see here that with antigen exposure, there's expression of PD-1, LAG3, so inhibiting that in the IO-therapy naive setting versus in the experienced setting, even after receiving something such as nivolumab, you can see that increased expression of LAG3 on the cells that could be a target for inhibition. So diving into the Relativity 047 trial here, you can see this was a global, randomized, double-blind, phase 2/3 study. So study of kind of the highest rigor. These patients were treated in the frontline setting, patients with a performance status of 0 to 1, and they were stratified by several different pathologic features, so LAG3, PD-L1, and BRAF status, in addition to their stage. Patients are randomized 1-to-1 to receive nivo-rela versus nivo, and the primary endpoint for this study was PFS, with secondary endpoints for overall response rate and overall survival. So the initial data that was presented last year, or published last year at the New England Journal of Medicine, was looking at 12-month follow-up for these patients. And you can see here that the combination of nivo-rela doubled the PFS compared to nivo single agent. So you can see here 10.12 months versus 4.63. Showing that 12-month PFS of 47 versus 36%. And so based on this data, the nivo-rela combination was approved for the treatment of adult and pediatric patients aged 12 or older with unresectable or frontline metastatic melanoma. We now have updated results. Looking at 24 months, we have continued sustained PFS here. You can see very similar to what was previously presented. And there's been additional presentation now of overall survival data, which you can see here that the median overall survival with nivo-rela has not been reached versus it's 34 months with nivo. So more to come there, but that's a secondary endpoint. So this study is primarily looking at PFS. Additionally, what was also presented was the confirmed overall response rate, which you can see at the bottom of the slide. So the combination of nivo-rela overall response rate was 43% versus 32%. And we'll probably come back to that later as we look across the treatment paradigm in that frontline setting and how to consider different treatments for our patients. So when we look at these, some of the factors for stratification, the hypothesis would be that a patient that has more LAG3 expression may be more likely to benefit. Potentially, this is what we looked at for the initial checkpoint inhibitors. Patients with more PD-1, PD-L1 expression may have a higher likelihood of response. But really what they saw, and you can see here, is that there was really a trend towards benefit regardless of LAG3 or PD-L1 expression. So patients you can see the LAG3 expression, patients that had greater than 1% did have a higher overall response rate at 47% versus 31%, but that was still not seen to be, that only patients with increased expression were benefiting. You can see here with the PD-L1 expression, again, there was a higher response rate for patients with PD-L1 expression, but then when they combined the two, you did see a little bit higher overall response rate, 54%, versus lower rates when you had, less LAG3 or less PD-L1 expression. When they looked at some other factors here, I think what's important just for the management of patients potentially is when you look at the overall response rate by age, that even in the older population, they had a similar overall response rate. We'll talk about toxicities and how this may be a regimen that's fairly well tolerated in this older patient population. And then importantly, they did include patients with acral and mucosal melanoma. So we know particularly for mucosal melanoma, these patients tend to have lower response rate with immune checkpoint inhibitors. And so it was nice to see inclusion of these patients and to be able to see about about 1 in 3 patients there were responding. Additionally, we saw no difference in response rate based on BRAF mutation status. So then looking at adverse events, and so you can see here a comparison of any grade versus the more severe grade 3, 4 toxicities with the combination versus nivo alone. And really what we see is that adding relatlimab, adding that LAG-3 inhibition didn't significantly increase the adverse events that we saw in patients. We also didn't see any new signals, any new immune therapy events that we really wouldn't expect with single agent anti-PD-1 by itself. And what you see here is, the most common symptoms that we usually see in patients: hypothyroidism, rash, diarrhea. And you can see there were very few patients that actually discontinued treatment with that addition of relatlimab compared to patients that had just received nivo. There's been a look at patients that have previously progressed on anti-PD-1, and so there was Relativity 020. This was a trial part D, and so this looked at nivo-rela in advanced melanoma for patients with progression during or within 3 months of either one or more than one anti-PD-1 containing regimens. And in this patient population, this refractory patient population, we do see, what I'd consider a little disappointing response rate of 12% in that first cohort and 9.2% in the patients that had received multiple prior anti-PD-1 or PD-L1 containing regimens. Although we'll, continue to follow up, the median duration of response was not reached in that first cohort. So for the patients that did respond, they may have durable responses. We'll follow with time. And you can see here the median PFS at the bottom was 2 and 3 months for those patient cohorts. So there are other LAG-3 inhibitor combinations in development, and one of these combinations is fianlimab and cemiplimab. And so fianlimab blocks that same LAG-3 MHC class II interaction, and cemiplimab blocks the interactions of PD-1 with PD-L1 and PD-L2. So this combination, the data at this point is from a phase 1 study, but this study was looking at several different cohorts, and what's presented here were, it's a little confusing, but a couple expansion cohorts. They were 6 and 15, so these were patients that were anti-PD-1, PD-L1 naive, and then you can see their cohort 7, that was PD-1 or PD-L1 experienced. So these patients all received fianlimab plus cemiplimab every 3 weeks for a year, and these patients were assessed kind of by standard study criteria, and you can see primary endpoint was overall response rate. So when we look at this combination, now keep in mind this was a single-arm phase 1 study, but in the patients that were anti-PD-1 naive, the overall response rate was 62 and 65%. So that's very impressive, right? More similar to what we see with Ipi-Nivo, but I think difficult to compare across studies. When you look at the combination of those two cohorts, so the full 80 patient number, you can see complete response rate was about 7%. Otherwise, most of those responses were partial responses, and the disease control rate was 64%. Here's the waterfall plot for these patients. So you can see a number of these patients. These are deep responses, and a number of these patients receiving complete response. And the picture at the bottom is one of those patients that had really had a nice response there in their lung metastasis. So one of the analyses that was just presented at ASCO, so hot off the press, was looking at this combination, the fianlimab, cemiplimab, in poor risk subgroups. So these are patients that have higher risk disease, so liver metastases, elevated LDH. And so you can see here that even in patients with liver metastases, the response rate was lower, but still 43%. And so that's still a really promising early signal for this combination. When they looked at patients that had an LDH elevated above the upper limit of normal, there you can see they still had an overall response rate of 53%, point that out there. And then when they combine these factors, these patients, the M1C, meaning visceral disease, and the elevated LDH, 35%. So I think certainly more encouraging data here with this combination. Here's looking at the PFS with this combination, and PFS so far has been reported at 24 months. So that's really exciting, and I think more to come. They also did an analysis looking at this combination stratified by LAG-3 and PD-L1 expression, and we see, similar to relatlimab and nivolumab, that patients, regardless of PD-L1 and LAG-3 expression, were benefiting. But we do see a trend in those patients with a response if they did have greater than 1% of that LAG-3 expression, greater than 1% of that PD-L1. Also, when we look at the toxicity profile, again, this is actually very, even adding that LAG-3 inhibition, the toxicity is still very similar to monotherapy. And so you can see here that their grade 3 or greater treatment-related AE rate was 20%, and rate of discontinuation was 15%. So most patients that had these toxicities were still able to stay on treatment and manage those toxicities. One thing that was probably a little bit higher than expected was the rate of adrenal insufficiency there. So treatment emergent adrenal insufficiency was 10%. So there is a phase 3 trial underway with this combination, so I think that's really going to be the true test. Obviously, we're familiar with seeing exciting phase 1 data, and that's certainly, I think, been compelling enough to launch a phase 3, but so I think more to come here with this combination. So you can see they're evaluating similar cohorts, so patients age 12 or greater, unresectable or metastatic disease, and they've got a couple different arms because they're looking at different dosing in line with FDA's Project Optimus, in addition to looking at pembrolizumab or cemiplimab monotherapy. So I think some of the take-home points looking at the PD-1 LAG-3 combinations is that certainly improved PFS compared with anti-PD-1. Unfortunately, we don't have any head-to-head data with Ipi/Nivo. That's not available. We may get some of that from real-world data. At this point, there's no data for CNS metastases, and we don't have a biomarker for selection. So in that frontline setting, we don't have something we can point to in the path report that helps us make that decision. The toxicity that we've seen is very manageable and much more comparable to anti-PD-1 than the combination with Ipi/Nivo. We do see lower response rates and a shorter PFS when it's given in the refractory setting. So I think the anticipation is this may not be, reversing that IO refractory patient, but is certainly a good option in the frontline setting. And we are seeing more combinations. So the fianlimab, cemiplimab is certainly a combination to keep your eye on. So just a reminder, the immune-related AEs, that the common management that we're used to for immune checkpoint inhibitors is kind of the same algorithms, that same process that you should be using with this new combination as you're familiar with single agent PD-1 or combination with anti-CTLA-4. And so this is taken from the standard guidelines, and I think they're really pretty similar across the different organizations between ASCO, NCCN, SITC, and ESMO. So moving on to a case. So this is a case of a patient in my clinic. So David, a 66-year-old man, he initially presented, I think he was actually being evaluated for heart evaluation, I think some type of cardiac procedure. They did imaging and had seen a lesion in the chest and had a PET CT that showed a number of subcutaneous lesions in addition to these spots in the chest. He had imaging with brain MRI that was negative, had a biopsy, one of the subcutaneous lesions that was positive for metastatic melanoma. He was a PS1, so he was obese, had hypertension, and the molecular profiling came back as BRAF wild type. So I think some questions for my colleagues here, is PD-1, LAG-3 preferred, or, looking at the other agents for IO, is this a patient that, would maybe push you more towards PD-1 monotherapy versus combination? So, Dr. Kendra, do you have some initial thoughts there if this patient kind of walked in your clinic doors?
So the big difference between single agent and combination in my mind is the potential added benefit worth the potential added toxicity. In someone who is asymptomatic, presenting with other medical problems, he had a cardiac something happen recently, looking towards something that's potentially a little less toxic may be better for this particular individual using more of a monotherapy type of approach.
Yep. So I think that's not, that each patient engaged different, individually. Um, we don't see this patient in front of us, right? So it's a little bit, hard to engage in that, kind of thing. I'd say in my practice, I have a pretty limited use of anti-PD-1 monotherapy anymore, and rather really discriminate into patients either get PD-1 LAG3 with, Nivo plus Rela, or for patients who have high-risk features where I would have previously given them Ipi-Nivo, I still defer to that. So, again, without other details, I think this sounds like a patient that I'd probably consider for the nivolumab and relatlimab combination. But, again, we don't see the patients, so it's a little bit hard to make those decisions.
And you mentioned, is there anything that would push you towards the CTLA-4, that patient that walks in the door?
Yeah, sure. So, historically, we've thought of Ipi kind of given that power punch behind PD-1, right? And which patients needed that at risk of getting the side effects of ipilimumab. And as we had thought about it, it was really patients who had features like brain metastases for sure, but even bone and liver metastases, elevated lactate dehydrogenase, and someone who's presenting with really rapidly progressive disease where, you're going to get one chance. So you got to give them the house, otherwise you're not going to get a chance, right? And so that's where I really think about it. And this sounds more like a patient, though, with low volume disease without those features. And so I'd probably defer, again, monotherapy is reasonable. I'd probably personally, go for the higher upside of efficacy response, but that's how I would think about it.
And Dr. Kendra, what's been your experience so far with, toxicity with the combination therapy with relatlimab?
Far less than with the Ipi and Nivo, far less. But we still do see adrenal insufficiency. We do see the hypothyroid state. We still do see some of that diarrhea. But far less common than we do with Ipi and Nivo.
Mm-hmm.
Dr. Luke?
Yeah, no, similar. I think I have to say in our practice, we read the toxicity more from the numbers in the Relativity 047 study because we haven't seen anything more than what we saw with PD-1 monotherapy. But it's the sample size that you have for your individual practice is always not really representative, right? So, but that's been we've done quite well in terms of toxicity.
Yeah. Yeah, I think it is always interesting as these newer agents kind of get out into practice to be able to see. But and I think you point out, each of us I think individually has a limited perspective, but I think very very appealing so far from an AE standpoint. Great, and then Dr. Luke, will emerging PD-1 LAG3 combinations have a role in this setting as well?
Yeah, so it was mentioned the cemiplimab plus fianlimab data, they look quite good in isolation. It's important to note that this cross-trial comparison thing here, I think, is very fraught. So I would not try to cross-compare response rates, except to say that it looks really good. And so if and when there's randomized data that really support that combination, I think it will be very competitive for a similar patient population.
Mm-hmm. All right, and so this patient did receive combination. You can see his baseline scan on the left and his follow-up scan after I think this is probably 3 restaging scans. I'm just showing a complete response. This patient actually hasn't had any immune-related AEs at this point.
That was an amazing overview of kind of the current state of checkpoint blockade. I think really emphasizes progress. I'm going to move on for the next talk to kind of talk about what do we do when patients fail standard checkpoint blockade in the first-line setting? What's going on in that space, and how do we think about that? What's exciting? To quickly introduce myself, I'm, I said Jason Luke. I'm at UPMC Hillman Cancer Center in the University of Pittsburgh. I'm the Associate Director for Clinical Research for the Cancer Center in general, and I run our early phase immunotherapy and drug development program, the phase 1 program, but obviously do a lot of cutaneous oncology as well. So to start, outcomes after progression on immune checkpoint blockade therapy really are not good, and we really need better options for these patients. And on the left, you see a Kaplan-Meier survival plot, emphasizing this point. It's a retrospective analysis, but really shows that survival is less than a year in patients who have progressed. And so sometimes there's a sense that, oh, it's melanoma, we fixed that problem. But no, we didn't. Maybe for upwards of half, we got a pretty good option, but we don't for the other patients, and they do very poorly. And it's important to emphasize that we don't really understand yet what the interaction is between our two frontline combo regimens that I just mentioned. So we have our PD-1 LAG-3, and we've had PD-1 CTLA-4, but what about sequencing them? There's going to be more data coming on this very soon, but the only data we have in the public domain right now looks at patients who got CTLA-4 monotherapy, IPI, or IPI-NIVO after LAG-3, and the outcomes were rather dismal. Again, they were very consistent with the previous analysis of less than a year of survival and response rates on the order of 10%. Now, I'm aware that more data will be coming from Relativity 047 to look at this more robustly, but it suggests that we're probably not in a situation of being able to salvage a lot of patients with a second immune checkpoint blockade regimen after they've progressed on combination up front. So when choosing a therapy in the treatment progression setting, we have several options, but none of them really are overly satisfying, right? So you can see on the left, this is NCCN. A lot of different sort of category 2 recommendations of things that you can try. I love this one down here, high-dose interleukin-2. I don't know when the last time anybody did that was, but and it should be emphasized that there are, in addition to BRAF, obviously, a number of other more rare genomic changes that you really should assay your patients for, because if you find them, you can really make a meaningful difference for these patients, again, noting their limited options. But there have been a couple of data sets that have come forward more recently that have helped to define a new treatment option. So one of them in melanoma is lenvatinib plus pembrolizumab. Lenvatinib is a complicated drug that putatively blocks VEGFR2 signaling, but additionally FGFRs, but frankly a lot of other things as well. And this is a schematic showing that and the impact of what lenvatinib can do in various different settings. Lenvatinib obviously having an impact on VEGF, and that can actually lead to polarization changes in tumor-associated macrophages, as well as induction of interferon signaling, which can amplify T-cell responses. And so through both of these mechanisms, there's a rationale for why a small molecule TKI could enhance anti-PD-1. And on the right, you see a mouse modeling the CT26 model, and just to cut to it, the combination obviously looks better than the other two. So based on this logic, you're well aware that lenvatinib and pembrolizumab is a standard of care in multiple different tumors, in kidney cancer, in hepatocellular carcinoma, et cetera. And in melanoma, we have data that support this now as well. These data come from the trial, which was the LEAP-004 study, which was a single-arm, non-randomized clinical trial that looked at patients with a very stringent definition of what constituted progression on a PD-1 and CTLA-4 antibody. They very much wanted to make sure there were no late responders on this clinical trial that would, you might call, contaminate the potential outcome analysis. And patients got pembrolizumab here at 200 milligrams, normal dosing, and lenvatinib notably at 20 milligrams PO daily. And for anybody who gives lenvatinib, the exact dose of lenvatinib matters a lot because different patients can only tolerate so much lenvatinib. And these are the data which I think suggest that this is an active regimen. Overall response rate at 21.4%, but 33% in patients who had progressed on both PD-1 and CTLA-4. And these data were presented at ASCO a couple of years ago with this waterfall plot to emphasize this. And this was a therapy that was active both in BRAF mutant and non-BRAF mutant disease. And in fact, this is now listed in the NCCN guidelines as a category 2 option for patients who have progressed. And many people now do use this as a default salvage approach, especially in patients who might have brain metastases after progression on anti-PD-1 combination regimens. And these were the overall survival and progression-free survival plots that are associated with this treatment. I'll note that for a immunotherapy backbone approach, these data are, not quite what we would really want. We're always looking for that tail on the curve idea that some patients are going to really long-term durable response. We don't so much see that with this regimen, but again, in the absence of anything else, this can still be a valuable treatment that can be given for patients. Now, this study concept was taken actually into the frontline metastatic setting in what was called the LEAP-003 study, combining lenvatinib and pembrolizumab and randomizing that against pembrolizumab monotherapy. I won't go into all the details because trial is being discontinued, because this trial actually read out recently was a negative phase 3 clinical trial in the frontline setting. So this combination will not be an option for patients in the de novo metastatic setting, but again, those previous data I mentioned before emphasize that is an active regimen in the salvage setting that can have utility, especially in those patients that might have brain metastases where options are really limited. So to move forward then, beyond that TKI combination, we have a lot of enthusiasm in melanoma around adoptive cellular transfer. And in melanoma, it's probably the first place that this is going to become a big deal outside of hematologic malignancies. And so especially in the context of autologous tumor-infiltrating lymphocyte therapy, which has been advanced to the form of a clinical therapeutic in terms of a drug called lifileucel. And this is slightly complicated to do, a little different than what you're used to, but not really that crazy to think about, where patients are identified and tumor tissue has to be procured. So a patient has to have a tumor resected. They have to go to the OR and have a tumor removed. That is then processed through a workflow through the company called Iovance, which took this out of the NCI and optimized this process, where through 22 days on a medium process, they can harvest the cells and then grow them up in cytokine support so they're ready as an autologous drug that's specific to an individual patient. So then the patient comes in and you give non-myeloablative lymphodepletion and then reinfuse their own tumor-infiltrating lymphocytes now into that niche that's been opened within the bone marrow and in the immune system for the presence of these cells. After infusion, patients are given as many doses as they can tolerate, up to 6, of high-dose interleukin-2, and then we assess for a response over time. And these data look quite promising through a series of cohort expansions in an original phase 1 clinical trial. Patients with treatment refractory melanoma received lifileucel in a couple of different cohorts, and they're noted here. 2 and 4 are the names of the cohorts. And what you can see is that in roughly similar size cohorts, you saw initially a response rate on the order of 34.8%, and then in cohort 2, the validation cohort, at 28.7%. So averaging it out 31.4%, and I think that's pretty meaningful, again, in a patient population for which there is really kind of no standard of care. And it's important to note some of these patients are in very long-term durable response after adoptive cell transfer. And I think these data are very exciting. It's probably the first indication where TIL therapy will become a standard of care because this approach is now under rapid review by the FDA, and we're hopeful actually that it may become a standard of care before the end of 2023. Now, another approach that's been longstanding in melanoma of interest is intratumoral therapy, and whether it's vaccine or another different sort of approach. And so the concept here is because in advanced melanoma, sometimes with cutaneous metastases, we can reach the disease. Can we do something, obviously, that would ablate the cancer, but might also be immunostimulatory that could enhance systemic immune responses more generally? And so the concept of oncolytic viruses have been very much at play in this sort of arena for a long time, where again, the concept is you load the syringe with oncolytic virus, you inject it, and it preferentially only infects the tumor cells where it can replicate and then both kill the cancer cells, but also generate a number of immunological signals that might help to amplify the activity of systemic immunotherapy. And a number of modifications have been made to these viruses. The most advanced of these viruses is obviously telamogene lahiperepvec, or TVEC, where unfortunately a combination that was studied with pembrolizumab was negative. But more recently, a virus called the RP1 virus, which is also a herpes simplex virus type 1, carries a number of different modifications of the virus to make it more aggressive against the cancer cells, and hopefully then to drive a greater effect in combination with anti-PD-1. And these are data that were presented actually, I think, at ASCO last year, and there's an update in an abstract this year I'll talk about in a second. But suffice it to say that in the initial evaluation of a small number of patients, they described a response rate overall in the order of about 40% systemic RECIST response rate. So not just where they injected the virus, but rather in the whole body they were seeing these effects. And I can tell you quite frankly, many of us were like, well, we've tried this a long time and it's never really worked. I'm not so sure about this. At ASCO here, just today, they presented a poster of 90 patients now. The exact same number holds up. 40% systemic response rate in patients that have already failed anti-PD-1. And I think these data are quite exciting. It's a little bit of a niche population. Not every patient has cutaneous centric disease metastasis, But for those that do, this is looking like a very promising therapy. And what we understand is that they're going to complete accrual and be able to go to the FDA with their total data set, possibly by the end of this year, maybe early next year. So it could be the case we have a second oncolytic virus approved for standard of care therapy as early as next year. And these are representative images of what you might call abscopal-like effects. So we inject this lesion, but you see these other ones are shrinking over time. And obviously these are liver metastases, not just cutaneous metastases, that we're trying to manage. Finally, there are two programs that I think you should be on your radar as very important, and I think actually probably will be field defining within the next 5 years. And they both surround the targeting of PRAME, which is a cancer testis antigen, which is disproportionately induced in melanoma cells. So for people that aren't like hanging out thinking about cancer testis antigens all the time, there are certain molecules in our body that are only expressed in the fetal state. And as we come out of that, primordial ball of cells, some proteins get downregulated. They're not supposed to be there. But cancer gets like super screwed up, especially melanoma, and turns some of these proteins back on. It's very useful because that actually marks self and non-self. Because a therapeutic strategy engaging PRAME, in this case, will not engage in other natural tissues in the body. Okay? And so that's very interesting because you could start to design immunological strategies that would only attack the PRAME, and that one of them is outlined here. So what you see here is a drug, and it's great, got a great name, IMCF106C. Just keep trying to say that over and over again. Someday it'll probably have a name. But this is a cousin, sister, brother, whatever we're going to call it, of the drug tebentafusp, which many of you are now aware is approved as the first therapeutic option for advanced uveal melanoma. Because the backbone is this ImmTAC platform, where there's a conjugation between a tumor-targeting antigen and CD3. And I explain this to my patients as basically like immunological tape. On one side of the molecule, you grab the tumor cell. On the other side, you grab the immune cells, and you just pull them together. And it turns out those immune cells, they don't like the tumor cell when they see them. This is an example of the construct that we're talking about here. So it's a targeting domain, which is the T-cell receptor that engages with targeting of PRAME, as well as an effector domain, single-chain variable fragment anti-CD3. And again, just physically pulling cells in. Now, important point is that because this is a T-cell receptor-based therapy, the therapy is restricted by HLA expression. And this is something that I think the general oncology community is going to need to get their minds around. People have heard of HLA testing in the context of bone marrow transplants, right? You have to match the incoming product versus the old one. But now our therapies are going to be designed to work in certain people's immune systems. And so testing for HLA-A201 is now a standard of care in uveal melanoma because the only approved therapeutic requires this. This is more and more going to become relevant in other tumor types as well. So in cutaneous melanoma is mostly a disease of Caucasians, obviously, and the expression of A201 is approximately 48% of all Caucasians, so about half of people will carry this natural genotype. And these are the phase 1 data that were presented at ESMO last year for IMCF106C. And what you can see is that there were a number of patients, actually both with uveal melanoma as well as cutaneous, that had partial responses per RECIST that look quite interesting. And these are all in patients who are refractory to immune checkpoint blockade, again, sort of suggesting that this could be a high priority treatment with further development. And there are a big clinical trial series ongoing now, something to think about if you have refractory patients that are looking for new treatment options. This is an example of a patient who got this kind of treatment, and you can see, these lesions that are shrinking over time. It's kind of our classic thing in oncology to feel happy about ourselves that this tumor got a lot smaller after we give the treatment. Now, there's another approach to targeting PRAME, which I also think people need to start being aware of. And as opposed to a CD3-directed tumor engagement, this is instead actually a transduction of a new T-cell receptor into an autologous product from the patient to re-educate their own immune cells to go after the cancer in a natural way. So it's a T-cell receptor-based engineering platform is another way to target PRAME. And the concept here from this product called IMA203 is that patients are identified as HLA-A201 because, again, you have to have the right genotype in order to have the T-cell receptor actually engage via the MHC complex. They are then profiled for the presence or absence of PRAME, and it turns out that in melanoma, PRAME expression is almost universal. Almost all patients have this. It seems to be a canonical aspect of the development of melanoma. In fact, we use it as a diagnostic criteria sometimes on primary lesions. And once this is done, we can leukapheresis the patient. So whereas, remember, I mentioned TIL therapy, we cut the tumor out, here we can take peripheral blood. And so this ends up being a lot more similar to what we do in multiple myeloma when we want to prep patients for auto transplant. You send the patient, they can get the blood out, and then they can take the blood and then perform a lentiviral transduction to insert the T cell receptor into the blood product, bring the patient back and give a low intensity lymphodepletion strategy, and then reinfuse those T cells back into the patient, which have now been re-educated to go after the PRAME molecule. And this is an early data series in phase 1, but what you can see here, this Kaplan-Meier plot, I think is pretty impressive. So in the first 11 patients who were treated in the recommended phase 2 dose, there are 7 responders, most of which are more than 50% tumor shrinkage. And so this looks like a very powerful technology to leverage, albeit this is a little more complicated than just giving anti-PD-1 immunotherapy, right? You got to find the right patient by HLA, you got to do a leukapheresis, you got to prep the patient, et cetera, et cetera. But I feel pretty confident that 5 years from now, this is the kind of therapy we're going to be doing, not just in melanoma, but in many other tumor types as well. So summary quickly, we talked about the landscape of melanoma therapeutics continues to move very quickly. That's really awesome for our patients, and I think from just a technology platform, it's pretty cool. We talked about autologous transfer of TILs, we talked about viruses, we talked about bispecifics, TCR T cells, et cetera. But all the same, we have a lot of patients that still pass away from melanoma, and that's not good enough, right? We think that TILs are probably going to become a standard of care option in 2023, possibly early 2024. But there are many agents in clinical development that look very exciting kind of moving into the future. So we'll talk about a case quickly about exploring options for progression after sort of standard immunotherapy. And so here, my patient, Mark, is a 73-year-old man who has metastatic unresectable melanoma. We gave him upfront PD-1 CTLA-4. He actually still has normal LDH, but he's kind of, not that strongest guy, right? He's a PS 1.9 kind of guy, like as we sometimes sort of talk about, right? BRAF wild type. So what are we going to do with this guy, right? I just outlined a whole bunch of different options here, and certainly any of them possibly could be an option, right? But I guess I'd kick it over to the team. We work at academic medical centers or large private, practices that have a lot of options for patients. How do you think about this kind of a patient? Maybe, Meredith, how do you want to start with that?
Yeah, sure. We talk all the time about trying to personalize therapies for patients, and I think a lot of the therapies that you mentioned, I think what personalized means can not only mean based on the molecular profile of the patient, being able to understand is this patient HLA-A02 positive, but then also even, the PRAME, that's weekly treatment. So can this patient come in weekly for treatment? The intratumoral, is this, what does the landscape of their disease look like? Do they have a lesion that could be easily accessed for doing intratumoral injections cutaneously or visceral? So I think, as we're getting kind of more novel approaches outside of just the immune checkpoint inhibitors and oral therapy with targeted therapies, I think we'll really be able to kind of narrow in on, for this patient, what are some of those other factors that might help us decide what's the best, both from a pathologic standpoint and then also from a personal standpoint, like transport to the clinics, family support.
Absolutely. And more comments you want to have about that? I mean, I think we live in the Midwest, and sometimes the distances are pretty big for patients, and we might have these great ideas, but it doesn't always work that way, right?
Yeah, the weekly treatments are a challenge for many, but for some, they're well worth it, especially if there's a therapeutic that has a good potential response for them. When it comes to the HLA profiling, it is a small number of people that is going to have that profile, but well worth being aware and looking for it. So yes, I think more of a personalized approach for that individual patient would be worthwhile.
Yeah. And I'll note that many of the routine next-generation sequencing platforms are starting to have some of this information on them. And I'm not sure everybody's totally aware of that. It used to be that when you got your NGS report, you got 50 genes, then it was 200 genes, now it's 400 genes. But it started to slip in there that the PD-L1 was also there. And actually, many of the vendors actually already provide the HLA profiling as well. So this isn't like some pie-in-the-sky thing you're going to have to go chasing around. It's actually probably already present in a lot of the data that you're getting back. It's just that you might not be looking immediately for it, but now you might be aware to be able to sort of take a double look.
The other piece that we didn't bring up with the last slide was with the TIL therapy. It's very intense, very short, and then they're done, and then they're free of us, which is very attractive to some people as well.
Yep. I think that's a good point. Well, so we're going to keep going, and we're going to talk a little bit about meeting treatment challenges with immunotherapy and resectable melanoma, and I'm going to keep the stage here to kind of just keep spieling along. I remain Jason Luke. in case you had not noticed, with similar credentials to what I had said previously. And I'm going to talk about advances in adjuvant immunotherapy and new directions in thinking about stage 3 and stage 2 melanoma, an area that I've done a lot of work in that I feel kind of passionately we need to get the message out a little bit more. So here we outline in a lot of detail, but guidelines and evidence to support adjuvant immunotherapy in stage 3, building on NCCN guidelines across the therapies that are approved. So anti-PD-1 with nivolumab, pembrolizumab, and then BRAF and MEK inhibitors with BRAF-MEK, dabrafenib, trametinib, et cetera. All obviously category 1 therapies across the board, and with roughly similar magnitudes of benefit, roughly approximately a 40 to 50% reduction in recurrence-free survival. And notably, even in comparison with other checkpoints, the CheckMate 238 study randomized patients to get nivolumab or ipilimumab and clearly showed a superiority of nivolumab versus ipilimumab with a 28% improvement even versus another checkpoint. And in a more pure sort of comparison, the Keynote 54 study looked at pembro versus placebo and saw this was even a little bit more, about 0.6. So again, like I said, about 40% improvement with immunotherapy in the stage 3 setting. So anti-PD-1 is clearly standard of care. I think probably everybody here already kind of knows that. One of the weird complexities, though, is whereas we've made a lot of success in metastatic disease with combination therapies, that's yet to be realized in the adjuvant setting. And we have a couple of studies that are at odds with each other in this realm. So the CheckMate 915 clinical trial was an enormous trial, ridiculously large trial, 1,800 patients to look at Nivo plus Ipi in the adjuvant stage 3 setting. And there were so many problems with this trial. It started out as a 1,000 patient trial, then it got modified to add a whole bunch of patients to look at something different. The dose of ipilimumab was completely wrong in this trial. They studied a completely new regimen of ipilimumab that had never been given to anyone with melanoma before. And as you can see, hopefully all the brainiacs in the room can notice that there's no difference, right? So this trial was totally negative. It was a complete disaster. I have a lot of friends at BMS who worked on this trial who feel very bad about it. But it is what it is, that this level of evidence obviously did not rise to the point of FDA approval, which on some level might be good, because I think a lot of us were reticent of the toxicity that we would think about giving in the adjuvant setting for Ipi-Nivo. We give that to patients for metastatic disease because we think we don't have a choice. We're not really that enthusiastic about doing that for patients who might be cured anyway. All the same, this never got approved. But the weird thing was, at about the same time, there was a clinical trial being run in Germany, and they called it the Immunotherapy trial, and this was patients with resected stage 4 melanoma, so metastatic disease but resected, who went on to get either Nivo mono, placebo, or Ipi-Nivo, and you can see there is this huge benefit in this population of patients. So how can it be the case there's an enormous benefit in patients with resected stage 4 versus there's no benefit in the rest of stage 3? It doesn't make sense. And I think it probably has to do something with the dose of ipilimumab used in these trials. In the Immunotherapy study, they used kind of the regular dose of Ipi 3, Nivo 1. And here they used Nivo plus Ipi 1 every 6 weeks. So it was a much lower area under the curve exposure in this trial. All the same, it's a huge headache, a big mess. It's not standard of care to use Ipi-Nivo in the adjuvant setting, but for some patients with brain metastases, I'd be interested in what people think, but I do use it sometimes in patients who presented with de novo brain metastases because I worry so much that when they recur, they'll have edema in the brain. We won't be able to give them anything. It'll be a total nightmare. But this is an area of confusion that remains in the field. But what about the role of LAG-3? And so this was already discussed. I won't, belabor this right now, but we saw a benefit in the metastatic setting in relativity 047 that was actually on magnitude, on absolute numbers, bigger for relatlimab than it was for Ipi. So Nivo-Rela, on an absolute basis, has a bigger delta for PFS and OS than Ipi-Nivo, and a much more attractive safety profile when we think about possibly applying this in the metastatic setting. So given that context, where else are we going to go? Well, we have a metastatic trial. It's how oncology works, right? We have a metastatic trial. It worked, so we better try it in adjuvant. So, of course, we're doing that now. There's a trial, Relativity 098, and I believe this is a fully accrued phase 3 clinical trial in the adjuvant setting. Very similar to all the other adjuvant trials you've ever heard of, stage 3 melanoma. Patients get Nivo-Rela at the same dose as metastatic, or they get Nivo, and then we follow up. So it'll be super, super interesting to see what the outcome of this trial is. Because based on the CheckMate 915 study, combo didn't beat mono in adjuvant. But there were so many problems with the previous study that we're not sure that's really true. And I think this would be a boon for patients, because if you're willing to tolerate the tox of Nivo, Relatlimab adds some. It's not, it doesn't add any, but it clearly adds a fair amount in terms of efficacy. So this could be a pretty big deal once it eventually reads out. Of course, we've had a lot of other movement in the field of adjuvant therapy in melanoma, and probably the big thing, well, definitely the big thing for us as melanoma docs here at ASCO is the update from the clinical trial of mRNA 4157 or V940, which we're calling now an individualized neoantigen therapy. It's not a vaccine anymore. So it's individualized neoantigen therapy. So what is this? Well, this whole field of neoantigens has been emerging in oncology for a long time, and we're aware that they can be immunogenic, right, in a personalized way. It's not the PRAME that I talked about before. It's not GP100. It's individual single nucleotide polymorphisms that show up after exposure to carcinogen that actually drive these immune responses. I won't go over the figure, but except to say that with modern technology, bioinformatic, computational power, we can actually now take a tumor, sequence it, and compare it to the normal in the patient. So take their peripheral blood mononuclear cells, get genomic DNA, compare that with the genomics in the tumor and say, okay, what's different? And then bioinformatically compare which of the proposed changes will turn into proteins that bind to either class 1 or class 2 and would be expressed on the surface of the cell and therefore could be observed by antigen presentation. And doing this, the company generated these vaccines which can then be delivered to patients. In a clinical trial, I talked about it already, we'll call it Keynote 942 for simplicity's sake, patients with very high-risk melanoma. So they allowed stage 3B, but no patients actually had 3B. It was all 3C or 3D, bulky disease that presented with resectability, went on to be randomized to either get pembro plus the personalized or the individualized neoantigen therapy for up to a year versus pembro alone as per standard of care. And importantly, the individualized neoantigen therapy was made and usually applied at approximately the third dose of the pembro, and they're continued throughout the rest of the year. And these were the data that were presented at AACR earlier this year, looking at recurrence-free survival. And what you can see is that it actually took a little while for the vaccine to kick in, such that the vaccine started being given kind of like right around, maybe around here, but you start to see the separation of the curves here actually at about a year, which becomes much more profound as you go further out. Again, to emphasize here, in the previous trials, we were comparing pembro to placebo. This is pembro to pembro plus the vaccine, right? So this is still the benefit of anti-PD-1 plus this delta, and look at this hazard ratio, 0.56. They almost doubled the impact on recurrence-free survival by including, did I say vaccine? It's not a vaccine. By including the individualized neoantigen therapy. So these data are really, really provocative. And of course, they're phase 2 data. This is not the biggest trial in the world, right? This is almost 200-patient trial. It's really, really exciting to think about what these data will look like when we actually do a randomized study in a registrational sort of perspective. I'm going to move on quickly then to also talk about stage 2 melanoma, something that I've been working on a lot over the last few years. We talked about stage 3, and I think it was just taken on faith. Stage 3, that sounds bad, right? Stage 3 means there's lymph nodes involved by AJCC. Patients must be at high risk, therefore we must give them adjuvant therapy. Except a weird idiosyncrasy of the AJCC and melanoma is that some of the patients with stage 2 have a worse melanoma-specific survival than the patients with stage 3. And this has been known for a long time, but never really dwelt upon because melanoma oncology was see derm, see surgery, then see med-onc, right? But if you look at these curves, you'll actually see that patients with stage 2C melanoma have worse outcomes than patients with 3A and 3B, which emphasizes the point that the risk of metastasis and death in melanoma comes from the primary melanoma on the skin, not from the lymph nodes. And yet, despite this being data that's been around like forever, I mean, we had the AJCC, I mean, I'm not that old, but like 20 years, 30 years, I don't know how long is old the AJCC. Everyone's known this forever, but when we ran the trials, we only did stage 3. We left out the stage 2 patients, but they're at higher risk than some of the stage 3 patients. Why did we do that? Well, that was the inertia, that was the regulatory landscape, it was what it was. So based on that, we busted our tails, me personally, for about 5 years to eventually get this clinical trial launched called Keynote 716. Keynote 716 was a very simple study. It said patients with stage 2B and 2C melanoma have a very high risk of recurrence, and I bet if we give pembro, it will reduce the risk, because turns out pembro works really good for melanoma. So we randomized patients to get pembro or placebo, and then we followed them up. And what was a validating thing for me, but super obvious and should have been so to the field, At the first protocol specified analysis in the clinical trial, 12 months of follow-up, the trial hit its primary endpoint, which emphasized two things. One, patients are at very high risk of recurrence. Two, pembro works for melanoma. But again, if we had polled you coming in, you probably would have known that, right? So this is not a surprising outcome, and yet really challenged the field. It has actually really turned things upside down in terms of referral patterns, because it's no longer appropriate that a patient sees a derm and goes to surgery. They should see a derm and go to a multidisciplinary team that includes a medical oncologist to think about when is the appropriate time to think about adjuvant therapy. And in fact, these data have been updated a couple of times. I presented the 12-month. Dr. Georgina Long at ASCO last year presented the 24-month update, and I'll be updating this trial on the oral session at ASCO on Monday, when many of you have already left probably to go home. But if you're still around, please come in and hear the update. We'll be updating both recurrence-free survival, but more importantly, distant metastasis-free survival, which shows an improving and enhancing benefit over time, consistent with what we know anti-PD-1 does in every other setting in medical oncology for melanoma. This was a subgroup analysis across Keynote 716, and essentially shows that basically patients with all different factors benefited from anti-PD-1. One that was really interesting actually was this one at the bottom. I don't want to dwell on it per se, but I think this is the one that has stood out to people. The presence or absence of tumor-infiltrating lymphocytes in the melanoma, the primary lesion, did seem to stratify the outcomes pretty strongly. And that's actually consistent with what we already know about anti-PD-1 efficacy in other situations, right? Where you have high PD-L1, it's a surrogate for infiltrating immune cells that are making interferon gamma, and we see something similar in this adjuvant setting. So one of the complaints about this is that, of course, if you go from stage 3 to stage 2, the number of patients at risk goes way up, because the number of people who have deep primaries but not nodes is much larger. In fact, it doubles the size of the number of patients. So could we better select who gets adjuvant therapy? And the answer right now is we actually can't. These might be hints about ways we might be able to do it in the future as we start to apply modern diagnostics as well as our clinical pathological factors. Now, in immediate response to Keynote 716, after I had tried to convince the company that does checkmate things to do this also, they then launched a companion trial called Checkmate 76K, which is basically the same trial, albeit with one slight difference. They included a 2-to-1 randomization so that patients were more likely, two-thirds would get nivolumab and 1/3 would get placebo. Otherwise, the trial is the same kind of RFS endpoint. And they showed a very similar outcome. It was a big benefit in terms of a 12-month recurrence-free survival. They hit the primary endpoint here. The hazard ratio here looks quite impressive, albeit with a little bit of weird idiosyncrasy about the control arm. In functionally speaking, pembro and nivo basically work the same in whatever situation you use them. So I wouldn't try to overthink this, except to say it's pretty clear that nivolumab works just as well as pembro, just like you would expect it would be, albeit that in this moment, anti-PD-1 with nivolumab is not approved by the FDA for use in stage 2, whereas pembrolizumab is. I would assume that will probably change over the relatively near term. And there are now data that phenocopy this and I think support the idea that this is a biologic phenomenon relative in stage 2. This was also consistent with DMFS, as I kind of alluded to. Again, no surprise. Pembro, RFS and DMFS, Nivo, RFS and DMFS, both consistent and helpful for patients with stage 2 disease. So next steps to think about. Adjuvant Nivo and Pembro in high risk. These are being investigated now with different biomarker stratifications. So there's a study in Europe called the Nivo-Mela study where they're trying to use ctDNA to select out which patients would be at high risk to actually give this therapy. The caveat here is that in melanoma, as opposed to other tumor types, detecting ctDNA is much more difficult. That probably seems kind of obvious. If the tumor's only this big, you don't have as much ctDNA as if you take out the guy's whole bladder, right? But all the same, it's a biologically informed approach that I think makes sense. There are other adjuvant clinical trials that are ongoing you should be cognizant of. One of them that's already launched is called the KeyVibe-10 trial. This trial combines pembrolizumab with the anti-TIGIT antibody called MK7684A or vibostolimab, as above here. This study has been designed to capture the entire approval. This is my idea. That they should just treat everybody who had stage 2B through stage 4, because all that, it works for pembro. So why, again, exclude certain patients? If we think this is really going to work, we should try it in everybody. And then the fianlimab plus cemiplimab, LAG-3 plus PD-1 combo is also being evaluated in an adjuvant clinical, will be soon evaluated in an adjuvant clinical trial. And they're also including stage 2C, you can see here, in that clinical trial. So another case that we'll go over to explore the use of immunotherapy now, we're talking about stage 2. So this time, my patient, Barbara, is a 42-year-old woman, and she's recently diagnosed with a stage 2C melanoma in the mid-back, and surgery is recommended, which that's a good idea. I'll note that, usually it's old guy, it's usually guys actually that show up with these huge lesions on their back, right? And it's somehow, I don't understand, they're often married too, which always makes me wonder a little bit about what's going on there, that this thing is on the back. But anyway, so, surgery is recommended, they do BRAF testing, it's BRAF wild type. Okay, so it gets taken off appropriately, right? And it turns out there is no nodal disease. And when we see these really bad lesions, we're always like, oh God, this is gonna be terrible. But it happens. Every once in a while, they do the node, and there's nothing. And you're like, wow, but you have to think back then, those melanoma-specific survival curves say these patients are super high risk. And it's probably not a perfect number in AJCC because the continuum of stage 2C is very broad. You can have a 4.1 millimeter depth melanoma, but you can also have an 8 millimeter depth melanoma, and they're all called the same thing, right? And so there's more nuance that would need to go into this. But given the issues of overtreatment, of toxicity versus benefit, this is still an area of some controversy. You can imagine my perspective, having heard what I just said, but I'm interested to get feedback here. Do you guys offer anti-PD-1 for all patients with stage 2B and 2C? Or how do you counsel people? Are there factors that you take into account in any of this? How do you think through this, maybe? And Dr. Kendra, you want to go first? And how do you think about this question?
If they have no contraindications to immunotherapy, I would treat. I think the risk is higher. I think the concern is there.
I mean, I'll say, I think adjuvant therapy, sometimes these are the longer conversations that you have with the patient in clinic, right? Patient with metastatic disease, especially with some of the data that we have with DREAMseq, you're starting with immune therapy. That patient obviously knows they need treatment. And so in the adjuvant setting, that's where you're really trying to discuss, okay, here's the benefit, here's a potential risk. You're 42, so you may develop hypothyroidism, may need thyroid supplement the rest of your life. So these are certainly the longer conversations that I have, trying to weigh with that patient the pros, cons, and where after that conversation. Okay, so now what do you feel about that?
Yeah, and I think it's a weird thing in adjuvant, and I say this to patient often cracks their brain. You'll never know if the adjuvant therapy worked. You'll only know if it doesn't work. And if you get a side effect from it, will you feel confident it was worth it? That's a really hard thing to think about, right? Most people go to the doctor and say, Doc, tell me what to do. And then we say, well, there are these percentages, and you might get this terrible thing, but it might be great, but you won't really know if you need it in the first place. It's hard, right? I think this goes to the bottom question, which is, what is the role of wider oncology management? I think this is where multidisciplinary management of melanoma is really, really important. Because one of the things that can happen for patients is they get told by the surgeon, your node was negative, therefore you're cured. But you're not, right? Potentially not, the things we said. And so this is where multidisciplinary teams are much better about this nuance, because if a patient is told after the surgery that they're fine, when they come see a med onc and we're like, yeah, we're gonna give you this treatment, it's got a 5% chance of giving you some terrible endocrinopathy, but it might cure the melanoma, right? They're like, what are you talking about? The other guy told me I was cured, right? So I think it really emphasizes getting patients into a group that can discuss all aspects of the risk and benefit that go along with adjuvant therapy, because it's not so straightforward. And I think it's very reasonable that some patients might say, I understand the potential benefit, but I'm very leery of toxicity, and I would prefer just to be observed. And that's okay, as long as they understand what it is that the pros and cons are in terms of that trade-off. We're going to move on to the final talk here from Dr. Kendra.
Hi, I'm Carrie Kendra, medical oncologist, and I'm in charge of the cutaneous oncology program at Ohio State University. When it comes to neoadjuvant therapy, there are several potential benefits to neoadjuvant therapy. The use of neoadjuvant therapy allows us to identify an individual's response to the therapy, whether it be a clinical response or a pathological response. Another potential benefit is that it can improve the surgical resectability of a tumor, decrease morbidity associated with that resection, and with that potentially improve the quality of life for that given individual long term. And ultimately, if the neoadjuvant therapy works, it can offer an improved relapse-free survival and overall survival. Biologically, when we look at the potential benefits of neoadjuvant therapy, if the immunotherapy is given while the tumor is in place, there is a potential for activation and expansion of a broader range of T cells, such that when that tumor is removed, those activated T cells can then work systemically to help clear that potentially micrometastatic disease that exists. First question is if we have a response, a complete response, what does that mean? Does it really tell us that the therapy is working well enough for us to go forward with that? This was a study that was performed. Patients were treated with either a single anti-PD-1 or a combination of the anti-PD-1 and anti-CTLA-4. While the pathological response rates were different for the different agents, as expected, the pathological complete response rate was reflective of a recurrence-free survival. So we have some evidence that does show that neoadjuvant immunotherapy can improve superior relapse-free survival as using the pathological complete response rate as a surrogate. There was a study that was presented at ESMO, SWOG's S1801, and in this study, they were looking at what would happen if we add neoadjuvant therapy on top of the adjuvant pembrolizumab for patients with melanoma. The patients enrolled on this study were stage 3B to oligometastatic resectable stage 4. These patients could have either cutaneous, acral, or mucosal melanoma, but they could not have brain metastasis. Patients were randomized to receive surgery followed by 18 cycles of pembro, which was standard, or to receive 3 cycles of pembro followed by surgery, and then complete the pembro with those 15 cycles. In this study, at a median follow-up of 14.7 months, the neoadjuvant-adjuvant group had a significantly longer event-free survival than the adjuvant-only group. The event-free survival at 2 years was 72% in the neoadjuvant-adjuvant group and 49% in the adjuvant-only group, again showing the benefit of neoadjuvant therapy followed by adjuvant therapy. The benefits were present across all subgroups, including those at higher risk, those with a higher LDH, and with the stage 4 deeper tumors. The use of the neoadjuvant pembrolizumab was safe. There's a similar rate of high-grade AEs in either group, and there were no new toxic effects of pembrolizumab in either trial group. In the neoadjuvant-adjuvant group, disease progression or toxic effects resulting in the inability to undergo surgery occurred in less than 10% of the patients. So with this study, using neoadjuvant pembrolizumab for 3 cycles, followed by surgery, followed by adjuvant therapy, looks to be beneficial in terms of event-free survival and a low toxicity. Another trial was looking at combination therapy. In the OPASA-NEO trial, patients were randomized to either receive the standard ipi/nivo dosing or to the reverse dosing, or to administer the drug sequentially. They then underwent surgery. The pathological responses seen were greatest when the combination therapies were used, but with the inverse dosing, we saw far fewer of the grade 3-4 toxicities than we did with the standard. So the flip dosing appears to maximize efficacy and limit toxicity of neoadjuvant therapy using the IPI at a 1 mg per kilogram dose and the nivo at a 3 mg per kilogram dose with significant pathological responses. Relapse-free survival after 2 years of follow-ups did show the curves as noted here, with arm A being more significant than arm B, but after median follow-up of 46.8 months, median relapse-free survival and overall survival were not reached. The PRADO study was looking at whether or not lymph node dissection can be omitted for certain patients after neoadjuvant ipi/nivo. In this study, patients would receive 2 courses of ipi/nivo. There would be resection of the most marked lymph node If a pathological complete response or a near pathological complete response were noted, as defined by less than 10% viable tumor cells, then that patient did not have a further nodal dissection and had received no further therapy, just follow-up. If those individuals were found to have a pathological partial response, meaning 10 to 50% viable tumor cells, they did undergo a lymph node dissection and then were followed with observation. If those patients had greater than 50% viable tumor cells, thus no pathological response, they did undergo completion lymph node dissection and subsequently received a nivolumab therapy as adjuvant therapy. The study, the PRADO study, confirmed the safety and the high pathological response rate of the neoadjuvant therapy, as seen in the OPASA-NEO trial. Omission of the lymph node dissection and omission of adjuvant therapy in patients with a major pathological response was associated with a better quality of life and resulted in a higher 2-year relapse-free survival. Patients with pathological partial response seem to have higher relapse rates than previously suggested and may potentially benefit from additional adjuvant therapy. And addition of adjuvant therapy plus or minus radiation in patients who did not demonstrate any pathological response did seem to improve 2-year relapse-free survival compared with historical data. So thus the response seen in the initial neoadjuvant setting can be used to drive subsequent surgery and subsequent adjuvant therapy options. Another neoadjuvant trial was the anti-PD-1 LAG-3, the next step in combination therapy. This was for patients with stage 3, B, C, or D, or the oligometastatic stage 4 melanoma, had no prior immunotherapy. They received the Rela and the Nivo every 4 weeks for 2 doses, and then underwent surgical resection. And then they continued on with the adjuvant therapy with assessment of clinical and radiographic follow-up. In this study, those who obtained a path response had a higher probability of relapse-free survival than those who did not demonstrate any path response, again confirming the value of the path response and noting the high pathological complete response rates that we saw in this study. S1512 was a neoadjuvant anti-PD-1 study for patients with desmoplastic melanoma. Desmoplastic melanoma is an amelanotic melanoma found in high sun-exposed areas, and with that has a high tumor mutational burden. When people undergo surgery for desmoplastic melanoma, they frequently require multiple surgeries, deep surgeries, and are left with these huge deficits in the head and neck, highly visible areas. So the purpose of this study was to see whether, if we gave the patients 3 cycles of neoadjuvant pembro, whether we could have a strong enough pathological complete response where we could potentially eliminate the need for these huge surgical resections in these patients. Patients were eligible if they had resectable disease based on a surgeon's definition and that they had residual disease post-biopsy. That residual disease can be confirmed either radiographically, clinically on exam, and validated with an FNA to confirm. Patients receive pembrolizumab every 3 weeks for 3 cycles. If they have resectable If their disease remained resectable, they could undergo surgical resection. If not, they were allowed to receive 1 more treatment and then proceed with surgical resection. In this study, we found a pathological complete response rate of 55%. A pathological incomplete response was defined as no viable cancer cells. And with that, 55% of these patients had a dramatic enough response that there is a potential there for us to minimize the use of surgical resection in this patient population. This is an example of the type of response that was seen, but this was a lesion on the forehead, and this was a response after 3 cycles of the neoadjuvant pembrolizumab. Complete evidence of clinical response. With resection, this patient would have had a large deficit, a big flap, and a huge scar on his scalp. Beautiful response. When we look at clinical responses, as in many of the neoadjuvant trials, clinical responses fall behind pathological responses. The clinical responses noted here, we did see a complete clinical response of 15%, 31% partial response for an overall response rate of 46%. Thus, neoadjuvant therapy with 3 cycles of pembrolizumab in patients with desmoplastic melanoma can have significant benefit for that patient. This study is looking at the PD-1 TIGIT inhibitors in the neoadjuvant setting. It's a keymaker U02, the substudy 2C. And in this study, patients were randomized to either receive pembro alone, pembro with a TIGIT, anti-TIGIT, or a pembro with the intratumoral oncolytic virus. Patients then underwent surgery and then received adjuvant therapy with pembrolizumab. What was seen here was a dramatic pathological response of 81% in the patients that received the anti-PD-1 and the anti-TIGIT. So there was a 73% pembro alone and an 81% pathological response with the combination. Toxicities were very consistent with what is seen otherwise. We did see slightly more in this arm right here with some of the anti-TIGIT. In summary, data supports the use of pathological response as a surrogate for relapse-free survival. Neoadjuvant adjuvant pembro has improved event-free survival compared to adjuvant pembro alone. Flip dosing, ipi-nivo, appears to maximize the efficacy and limit toxicity of the neoadjuvant immunotherapy. Desmoplastic melanoma, a unique subtype, demonstrated pathological complete response rate of 55%. In the PRADA trial, the omission of lymph node dissection and omission of adjuvant therapy in patients with a major pathological response is associated with better quality of life and resulted in a high 2-year relapse-free survival. Patients with a pathological partial response, because they're higher relapse, may need more therapy. Neoadjuvant rela-nivo demonstrated a high pathological complete response with the combination therapy. And pembro plus the anti-TIGIT appears to be active in the neoadjuvant setting. There's a growing body of phase 2 and phase 3 evidence supporting the use of neoadjuvant immunotherapy in melanoma. From the current NCCN guidelines, consideration of neoadjuvant therapy, preferably in a clinical trial, should be considered for node-positive melanoma. We now have a case. We have Alice. She's a 69-year-old woman. She was diagnosed with melanoma of her left cheek and underwent resection in 2015. On observation in 2021, she presented with a lump on her left face and weakness in the corner of her mouth. An FNA of that fullness was performed, and she was found to have a lymph node that was positive for melanoma. CT of the neck, chest, abdomen, and pelvis was obtained, and a mass was found in the left parotid tail, measuring 2.5 by 2.7 centimeters. There was some indeterminate left level 2 lymph nodes and several small adjacent level 2 to 3 lymph nodes. On clinical exam, the mass was palpable. There were no other significant clinical findings and no other significant medical history. Genomic testing was performed. Her tumor had an NF1 testing. Her BRAF mutation was the G369. So the question is, what options are next? Do we consider neoadjuvant treatment? Do we consider surgery, then adjuvant treatment? And what is the role of the wider management team? So I turn to our team here for some discussions.
Great. Well, I mean, I think the last question is probably the most important, is that wider team management. You know, I think any of these patients that come in with, locally advanced disease, it's like critical to make sure that you've got, the medical oncologist speaking with your surgeon, the input from the radiation oncologist, the dermatologist, because it certainly sounds to me like this patient should be at least considered for neoadjuvant therapy. I know one of the things that kind of gets forgotten is those neoadjuvant trials. It was all resectable disease up front, right? Those studies weren't designed to take a patient and make them resectable. So that's still something to consider implementing those trial data into practice. So I think certainly, this sounds like it would be a pretty morbid procedure. So I think it's certainly worth considering with your team. Hey, is this a patient that might be a trial candidate? Looking at the SWOG 8-1 data, what can we do to help this patient?
Yep, and so I agree with all of that. And I'd point out one thing I think we didn't dwell on, but it would be a little nugget in case you have to take the boards or something. That NF1 mutation really gives something away here. So NF1 mutations are disproportionately present in desmoplastic melanomas and are associated with extremely high levels of tumor mutational burden. And this, she didn't have time to go into it. Dr. Kendra led a trial looking at that exact indication, and it's just like astronomical CR rates. So I think there's actually a little bit of a tweak here about, what's the role of the wider team. There might actually not be a role for surgery in this patient because the likelihood of complete pathologic response is so high. This patient might actually not end up going to surgery if they get anti-PD-1. But to this point, let's not presume that. Let's get everything queued up and ready. But this patient has a very high potential to do extremely well with neoadjuvant anti-PD-1, but albeit should be done in the context of risk management, right? Plan for the worst, hope for the best kind of situation, right? But I think that's another little nugget there that you can be aware of. If you see an NF1 mutation, it probably means desmoplastic. That means a very high chance of response to checkpoint blockade.
Yeah. So this patient, we had not had our desmoplastic data out yet. So she was treated at 1801, and she had a complete pathological response with her neoadjuvant therapy.
We have 7 minutes left before the end of the program. And I think from here, we're really interested to get any Q&A that you might have. And I think, I don't know if there are microphones around, but you can yell and we can repeat the question. To get started, I think one question that's on here that I think looks very interesting actually is it was mentioned the Prado trial of, I think what they meant by that was identifying the node and dictating treatment based on that. And there's a question of, have any of you actually done that in clinical practice? And so
I haven't yet.
Uh-huh.
No.
We tend not to do a lot of nodal dissections based on MSLT2 data.
Uh-huh.
So we tend to follow more with ultrasounds.
Okay, well, that's really interesting, actually. So we have a lot of neoadjuvant trials as well, although we have not taken it upon ourselves to go that far yet as well. I think our surgeons still are not convinced that that's a way to go. I'd say that I think the data look quite promising, but I think that's probably in the standard of care setting, we probably don't want to be not pursuing curative intent procedures until we have really definitive evidence that that's an okay thing to do. Questions from the audience? We have a mic. I used to have longer hair. No questions about that? No? Anything? No?
So the biggest challenge I run into is treating patients after they've developed toxicity from Ipi/Nivo. So they have pneumonitis or colitis that required steroid therapy for a protracted time. They're not candidates for trials, et cetera. What are you guys doing for those folks?
Well, I can get started. So in the phase 1 unit, it seems like that's a predominance of the patients that we see. Like, hey, this patient had bad IO tox to Ipi/Nivo. What else do we have? And the way I look at it is two things. So one, make sure you've done full profiling, because even if they're BRAF negative, there may be some other target that might still be available to that patient on a clinical trial, or potentially even something off-label if the KIT mutation or something else. But certainly there's more studies now for NRAS for atypical BRAF mutations. The other thing is sometimes a common scenario is a patient that maybe tolerated anti-PD-1 adjuvant fine and then got Ipi/Nivo recurrence and just had terrible colitis. Sometimes those are patients that, if they've had a break off of therapy, you could actually try PD-1 monotherapy again to see how they tolerate it. To see, sometimes I've had patients that have had a great response, and then B, that opens up trial options for them again, because I think that toxicity we see with ipilimumab is novel to itself. So those would be some considerations I would think through.
We would look to the phase 1 trials as well.
The comment I'd make about it is that, if you don't have trials, like what do you do with the patient? There are retrospective series to try to look at what's the incidence of reinducing a really high-grade event after re-exposure to checkpoint blockade. It's not as high as you would think. So with patients who got Ipi, re-challenging only led to a toxicity of significance again in a third of cases. So what that tells me is that it's all about informed consent, right? If you have the patient in front of you who's progressing, they might have something bad happen to them again if you give them checkpoint blockade again, but something will be bad if you don't do anything, right? And so that's where I talk to them about, what do you want to do, right? I have a patient right now who had, we gave him Ipi-Nivo, and he got brain mets, and also got terrible colitis. And so we got him through that. It turns out he's BRAF mutation, so we're putting him on that. But what are we going to do when he eventually progresses on BRAF? We know he's gonna. I've already started talking about, would you want to do lenvatinib and pembro, or just lenvatinib in that scenario? Because he's not going to be, he's got brain mets and tox, and he'd probably go for the combo because he wants the biggest upside he can get. And if it turns out something bad happens again, then he's educated. So I think it's that kind of like level setting with patients. All of you know better than I do, but regular clinical practice is not clinical trials. You work with what you got, and you educate the patient. You make the best decision you can, and sometimes that works out well, and sometimes it doesn't work out as well as you would.
And brain mets are slightly different than when someone doesn't have brain mets, right? There are different categories. The brain mets, we do try to be more aggressive with combination therapies of different types. When they're not in the brain, we look outside. So can they get a TVAC injection or some type of intralesional therapy to tackle it as well? Can they tolerate single agent Nivo and just bypass the Ipi if it's not in the brain, right? So looking at other ways to sort of modify, do we combine the Nivo with some type of radiation to get that abscopal effect if we think that they can tolerate the Nivo, but it's not great enough to give us a response for where their disease is sitting?
Sure. There's some good questions here also. Go ahead. Sure.
Yeah, when you show the PRAD results, you mentioned that the subgroup of patients with partial response had a higher relapse rate than we are expecting compared to the previous data. What do you think is the explanation for this difference for this subgroup of patients?
So those here who had that partial response, partial pathological response, they did have a nodal dissection, but they received no adjuvant therapy. So this is the group that may benefit from that adjuvant therapy more.
And I'd emphasize on that. We feel very confident about what happens to patients who have complete pathologic responses. What happens to anybody who doesn't have a complete pathologic response or near pathologic response remains like a gigantic wide open question. We don't really know what to do with them. And so should you switch from PD-1 to BRAF if you can? Should you escalate to Ipi-Nivo somehow? Like nobody knows the answer to any of these questions. So you hear a lot about neoadjuvant. Everybody's like really excited about it because we really like it when it works. When it doesn't work quite so good, we're actually not sure what the answer is yet. But more to come. And I think as the standard of care transitions, we'll get a lot more evidence over time. So I think that was a great review, and I hope that all of you found that to be useful. With that, again, thank you very much for your time tonight. I hope it was useful, and appreciate you coming out.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/GUW860. This activity is supported by independent educational grants from Merck & Company Incorporated and Regeneron Pharmaceuticals Incorporated.